Oxygen therapy. Used to treat acute hypoxemia by increasing oxygen levels in the blood and alveolar. Decreases the symptoms of hypoxemia including dyspnea. Decreases the workload on the heart. Signs of hypoxia. In respiratory. Mild to moderate and severe. Mild to moderate signs include tachypnea, dyspnea and paleness. Severe signs include tachypnea, dyspnea and cyanosis or blueness. In cardiovascular. Mild to moderate and severe. Mild to moderate signs include tachycardia, mild hypertension and peripheral vasoconstriction which stops blood from going anywhere except major organs and skeletal muscles. Severe signs include tachycardia then bradycardia, arrhythmia and hypertension then hypotension. In neurologic. Mild to moderate signs include restlessness, being disoriented, headache and lassitude or being lethargic. Severe signs include somnolence, confusion, blurred vision, tunnel vision, impaired judgment, slow reaction, coma and being manic-depressive. ARC oxygen therapy guidelines. You must have documented hypoxemia as evidenced by a partial pressure of oxygen less than 60 mm of mercury or oxygen saturation of less than 90% while breathing room air. Acute situations in which hypoxemia is suspected are severe trauma, acute myocardial infarction also known as a heart attack, short-term therapy or surgical intervention, oxygen toxicity, areas affected, lungs and CNS. CNS effects. Negative CNS effects include tremors, twitching and convulsions. Looks similar to bronchopneumonia by causing infiltrates on the lower lung in an X-ray. Negative process on the lungs. Process of damage. Damage the capillary endothelium. Damage the interstitial edema. Thickens alveolar capillary membrane. Alveolar fluid buildup. Low ventilation and perfusion ratio, psychologic shunting and hypoxemia. Then hyaline membranes form in alveolar region. Then pulmonary fibrosis and hypertension develop. Two factors that determine the harmful effects. Partial pressure of oxygen and the exposure time. COPD stands for chronic obstructive pulmonary disease and is characterized by airflow limitation that is not fully reversible. Some patients with COPD hyperventilate when given oxygen is most likely because of suppression of the hypoxic drive. Increase in the blood oxygen level in these patients will suppress peripheral chemoreceptors, decrease ventilator drive, elevate the partial pressure of carbon dioxide. Retinopathy of prematurity. Abnormal eye condition in premature infants who receive supplemental oxygen. Retinopathy of prematurity. Cause. Excessive blood oxygen which leads to retinal vasoconstriction which then leads to dead blood vessels. New vessels will form and multiply. But the new vessels are delicate so they hemorrhage and scar. The scars may cause retinal detachment or blindness. Absorption atelectasis. The significant risk level is when fractional inspiration of oxygen is greater than 50%. The effects are high oxygen depletes nitrogen levels. Then the pressure of venous gases decreases. The gases at atmospheric pressure in cavities then diffuse into venous blood. Alveolus collapse due to constant decrease in pressure. Collapsed alveoli are perfused but not ventilated. Absorption atelectasis increases. Psychologic shunt and worsens. The blood oxygen. Fire hazards of oxygen. In the operating room these are electronic scalpels as well as higher oxygen concentration under drapes. With home patients. Smoking or cooking while on oxygen. Lab time. Oxygen delivery systems. 3 basic designs. Low flow. Reservoir. High flow. 2 performance indicators of oxygen delivery system. One is how much oxygen it can deliver or the fractional inspiration of oxygen range and or limit. And 2 is the delivered fractional inspiration of oxygen. Fixed or can it vary based on demands? Low-flow systems. Supplemental oxygen is given directly to the airway at 8 lpm or less. Low flows are always diluted with air. They all have a variable fractional inspiration of oxygen. Nasal cannula. Used for spontaneous breathing hypoxemic patients. 4 sizes they come in are adult, pediatric, infant, and pre-ME. It produces fractional inspiration of oxygen from 0.24 to 0.44 FiO2 at flow rates of 1 to 6 lpm. 5 cons of nasal cannulas are: they irritate the nose, causing dryness and bleeding. They can have kinks in the tube. They can irritate skin, and they are easy to come out. Also, some people breathe through their mouth. Reservoir cannulas. Reduce oxygen supply use compared to cannulas. They are more expensive than regular cannulas and they are heavier than nasal cannulas. 2 types of reservoir cannulas are: the mustache, which holds about 20 milliliters, and the pendant, which holds about 40 milliliters. Pulse demand systems provide oxygen on inspiration, and they connect to 50 psi, so no flow meter is needed. They can be set at 1 to 5 lpm. Also, they won't cause dryness. Simple oxygen masks deliver 5 to 10 lpm and 0.35 to 0.5 of FiO2. They come in 3 sizes: adult, child, and infant. They also have a variable FiO. They are typically for short-term use. The cons of a simple mask: carbon dioxide rebreathing due to low flow. Breathing in vomit if unconscious. Also, you have to remove to eat or drink. Nasal catheter is short-term during procedures. It has a soft hose with holes at tip placed through nose and behind uvula. Then it is taped to the bridge of a nose. You must replace it and rotate nostrils every 8 hours. They are never used on neonatal babies. The transtracheal catheter is inserted in trachea between 2nd and 3rd ring. It has such a low flow no humidifier is needed. It builds up oxygen in the trachea and upper airway during exhalation. Cannulas are half as good at achieving partial pressure of oxygen than the catheter. It delivers 0.22 to 0.35 FiO2 at a flow rate of 4 lpm or less. The partial rebreathing mask delivers a minimum of 10 lpm, with 0.4 to 0.7 FiO2, but it is varied. It has a short-term use for therapy or emergency situations. It is basically a simple mask plus a reservoir bag. The bag holds 300 to 500 milliliters. During exhale, 1/3 goes in the bag and 2/3 goes out the ports. The non-rebreathing mask is basically the partial rebreather plus 3 valves. 1 valve keeps exhaled air out of the bag. 2 valves keep inhaled air coming from room air. Must keep it at a high enough flow to keep the bag inflated during inhale. As a safety measure, 1 exhale valve is removed. It delivers 0.6 to 0.8 FiO2. The non-heated high-flow nasal cannula delivers up to 15 lpm. You must use it with a specific humidity bottle that must be filled. High-flow systems supply oxygen concentration equal or more than the patient's peak inspiratory flow. It uses air entrainment or the blending system. You mix air and oxygen to create fractional inspiration of oxygen. The 2 main air entrainment systems are the air entrainment mask or Venturi mask and the air entrainment nebulizer. The patient in which air entrainment systems are great for are COPD patients. These patients usually require a fixed fractional inspiration of oxygen between 0.24 to 0.35. The gas plus low FiO2 flow is usually enough for patients' peak inspiratory flow. The Venturi mask uses low to moderate oxygen levels and has a fixed rate of 0.24 to 0.50 FiO2. The nozzle diameter equals the oxygen flow. The nozzle outlet equals the room air flow. ND plus NO equals oxygen concentration. E plus NO equals oxygen concentration. Air entrainment nebulizers are able to add humidifiers and temperature control. They have a range of 0.28 to 1 FiO2. Be cautious of moisture collecting in tubing that will cause increased fractional inspiration of oxygen. 4 types of air entrainment nebulizers are: the aerosol mask, the tracheostomy collar, the trachea tubes and the phase tent. Heated high-flow nasal cannulas produce up to 0.9 FiO2 and 90% humidity at up to 50 lpm. The fractional inspiration of oxygen is consistent regardless of breathing pattern, and it's used to treat moderate hypoxia. The 3 main features of heated high-flow nasal cannula are: it delivers high fractional inspiration of oxygen. It meets or exceeds the patient's minute volume. It will generate distending positive airway pressure. The 3 cons of heated high-flow nasal cannulas are: it can't be used if the patient has blocked nasal passages. Also, you are unable to monitor positive pressure to the airway. Also, nasal skin erosion can happen mainly on neonatal babies and infants with improper fitting cannulas. The blending system consists of air and oxygen mixed manually or with precision valve. Manual blending requires calibrated high-flow meters of at least 60 lpm and fractional inspiration of oxygen monitoring. They provide precise control on fractional inspiration of oxygen and total flow. The oxygen blending process starts as air and oxygen flow to a proportioning valve. Then varied sizes on air and oxygen inlets control the concentration. The fractional inspiration of oxygen is calibrated with an oxygen analyzer that is kept in line at all times. Enclosures are used on infants and children. There are 3 types of enclosures: oxygen tents, hoods or oxyhood, and incubators or the isolette. Oxygen tents are not really used anymore. The open and closing as well as leaks affects the fractional inspiration of oxygen. Hood or oxyhoods are used on infants for controlled oxygen therapy. It covers the head and is delivered by heated air entrainment nebulizers or blending systems with heated humidity. They have a minimum flow of 7 lpm. Incubators or isolettes have combined convection heating and oxygen flow. Due to leaks and reopening, it dilutes oxygen levels to less than 0.4 FiO2.